final poster in our rapid fire presentation is entitled The Use of Point-of-Care Bacterial Autofluorescence Imaging in the Management of Diabetic Foot Ulcers, a pilot randomized controlled trial. This presentation is given today by Dr. David Russell, who is a consultant vascular surgeon with Leeds Teaching Hospitals NHS Trust in Leeds, United Kingdom. He's also Associate Clinical Professor at the University of Leeds in Leeds, UK. Dr. Russell.
Hi, my name is Dave Russell. I'm a consultant vascular surgeon with a clinical academic interest in diabetic foot ulcer management from Leeds in the United Kingdom. I'd like to thank the organising committee for the opportunity to present our research on the use of point-of-care bacterial autofluorescence imaging in the management of diabetic foot ulcers. MolecuLight provided dart drape covers to support the trial, but had no contribution to trial design, funding, or analysis. We have no other disclosures to declare. Approximately 416 million people worldwide have diabetes, and this number is expected to rise to 642 million, or 10% of the world population, by 2040. A quarter of those will develop a foot ulcer. The health-related quality of life of those with foot ulcers is similar to those with amputation in terms of physical function, mental well-being, and social interaction. There's also a financial burden on healthcare systems, with the UK NHS spending £1 billion on diabetic foot ulcer healing in 2014 to 15, or over £1 in every £150 it's spent. Treatment as usual for diabetic foot ulcers should ideally be delivered within multidisciplinary diabetic foot clinics with community dressing changes in between. The visit should be fortnightly with sharp non-surgical debridement performed at each visit. Offloading provided, ideally with a Bologna walker or total contact cast, management of infection, and identification and management of ischemia. However, even with this care in the UK National Diabetic Foot Care Audit of over 23,000 ulcers shows that only 48% of patients are alive and ulcer-free at 12 weeks, which suggests the need for new technologies to aid ulcer healing. Bacterial wall porphyrins demonstrate autofluorescence under appropriate stimulus, and the strength of the signal is proportional to the concentration of active bacteria. MolecuLight emits a 405 nanometer or violet blue wavelength with dual band filter in a system which allows the distance from the wounds and the surrounding ambient light to be controlled, meaning autofluorescence only occurs at 10 to the 4 colony forming units per gram or more. The literature to support the clinical use is limited to microbiological confirmation of the system and case series. Our aim, therefore, was to assess the clinical effectiveness and decision-making associated with the use of bacterial autofluorescence imaging in the management of diabetic foot ulcers by performing a single-center pilot randomized controlled trial with blinded outcome assessments. The primary objective was to describe the proportion of ulcers healed at 12 weeks in diabetic foot ulcers in patients managed with or without the use of MolecuLight. And the secondary objectives were to describe the changes in ulcer area at 4 and 12 weeks between the randomization arms, and also to assess the changes in management decisions based on the information provided by MolecuLight. In order to do this, we plan to randomize 60 patients in a 1-to-1 allocation ratio using sealed envelopes to either autofluorescence guided treatment as usual or treatment as usual alone. The randomization was stratified by ulcer location, being forefoot or mid or hindfoot, and vascular status, being neuropathic or neuroischemic. Assessments were performed at baseline, 4, 8, and 12 weeks. These included ulcer area and healing with blinded assessments at weeks 4 and 12, adverse events including infection, hospitalization and amputation, and quality of life measures, the EQ5D5L and the disease-specific diabetic foot ulcer scale short form. Management decisions post autofluorescence imaging were at the discretion of the treating clinician. Inclusions and exclusions were fairly broad, including adults with diabetic foot ulcers. Exclusions included those with clinically infected ulcers at the time of randomization, significant renal impairment, ischemia sufficient to compromise healing, immunosuppressive therapy, or conditions other than diabetes, such as dermatological or rheumatological conditions, as the cause of their ulceration. We assessed 435 patients for eligibility within our clinic, 357 of which did not meet the inclusion criteria. A further 22 did not consent to randomization, meaning 56 patients in total were randomized. In the autofluorescence imaging guided treatment, 29 patients were randomized, of which 1 was lost to follow-up and 1 patient died. In the treatment as usual alone group, 27 patients were randomized, with 3 lost to follow-up and 1 withdrawal. However, our analysis was performed on a worst case scenario, so all patients were included in analysis. Turning to the results, the groups were well matched in terms of age, sex, SIMBAD score, and wound area at randomization. The randomization strategy also ensured there was no difference in site of ulcer or vascular status between groups. We were able to show a significant improvement in the primary outcome of healing at 12 weeks between groups using worst case scenario analysis, with 45% of patients in the autofluorescence imaging guided arm healing versus 19% of patients in the treatment as usual arm alone arm. There was no difference in median wound area reduction between the groups at 4 weeks, but a non-significant increase in wound area reduction seen in the autofluorescence imaging guided arm at 12 weeks. There was no difference in quality of life measures between groups at any time point. Looking specifically at those patients in the autofluorescence guided arm, we were able to divide the groups into those that were negative at week 0, demonstrated in the green in these box and whisker plots, versus those who had positive imaging with targeted intervention in blue, and those who had positive imaging with no targeted intervention in yellow. The scale shows wound area reduction between baseline and week 12, ranging from 100% reduction or healing at the top, through no change to 100% increase in size at the bottom. You can see a non-significant stepwise reduction in wound healing from negative autofluorescence imaging to positive imaging with no intervention. The main intervention, over 80% of cases, was targeted debridement, with a small number having dressings changed to those with an antibacterial component. There was no change in antibiotic prescribing as a consequence of the autofluorescence imaging. So in conclusion, ladies and gentlemen, this pilot study is the first randomized controlled trial assessing the use of autofluorescence imaging in the treatment of diabetic foot ulcers. In this trial, autofluorescence imaging improved ulcer healing at 12 weeks when added to standard care, with the main intervention being additional focused debridement. Autofluorescence imaging may also be useful as a tool to triage wound care by identifying wounds most likely to heal without advanced interventions. Thank you for your time, and I'd be very happy to take any questions. Thank you.
Thanks, Dr. Russell, for a great presentation. This is really the, I think the different technological products that are being introduced now are leading us into, a whole cutting edge of a clinical practice at this point in time. So now I'd like to begin with some questions and answers. But before we entertain any from the audience, I would like to ask you one particular question. And what is fortnightly?
Every 2 weeks, 14 days.
Okay. I didn't know. I went, what's fortnightly? And I thought, no, I'm not going to Google it. I'm going to ask him, but I have him on the screen. So fortnightly is every 2 weeks. Okay.
Apologies for the Britishness.
Okay, and I understood that, but I thought, I want to know this. All right, a question that we have. What was used topically? For instance, from a dressing perspective, to reduce bacteria colonization?
So we have fairly limited options in the UK. So typically silver dressings or honey would be the 2 most commonly applied dressings with an antimicrobial activity. So we have much less access in terms of wound cleansers than perhaps is available in the US. Prontosan So polyhexanide is probably the only option we have, and that's rarely used in the UK. So typically the dressings would be either honey-based or silver-based dressings.
Or silver. Is cardoxim iodine available to you?
It is, but used less commonly.
Okay, and the silvers are more commonly used. Okay. A question. When you discussed debridement of the wound, I mean, we think of debridement and we think of removing the visible necrotic non-viable tissue. Now, when you have a product like MolecuLight, you're identifying bacteria and potentially subsurface bacteria, and I'm thinking of areas of wound undermining. So now, if you have any undermining, are you then extending that debridement? Is molecular, one, are you extending that debridement and more or less performing what I would say would be an excisional debridement, if you will, of the tissue that's over the undermined? I mean, a term that was used, I have come across, was saucerization.
So in both groups, they had standard debridement with a surgical blade in clinic, as would be performed routinely by our podiatrists prior to MolecuLight imaging. In the group that also have MolecuLight imaging, they have imaging post-debridement at that stage. And if they were still positive, then about 80% of patients who had an intervention based on that positive result had further debridement to try and eliminate that residual positive area. So yes, a more excisional debridement at that point.
May indeed occur. I was curious about that because it just seems like such an area where bacteria can harbor. Where do you see this MolecuLight technology extending as far as into your clinical practice outside of trial?
So following the results of this, we've really progressed use of the technology in two areas. So firstly, particularly in wounds that are failing to hit a healing trajectory at 4 weeks, we would include a MolecuLight assessment as part of that. The second issue we have, as I'm sure a large number of diabetic foot centres around the world have, is increasing problems with capacity, and we're looking to offload some of our capacity to community clinics, and we feel that those that are negative for MolecuLight and on a healing trajectory are probably the lowest risk group for complications, and probably the best group to move out to a step-down clinic. And therefore we're also looking to use MolecuLight as part of our triaging to pick patients that can be stepped down to a community clinic rather than a central MDT diabetic foot clinic.
That's very interesting. So you're actually triaging to different levels of care based upon your findings. Interesting. Well, I find it all very interesting because I happen to really love bacteria. So to me, this is just a great tool to have. So thank you. Thank you. It was a great presentation. I have more questions, but we do need to wrap up now. And I'm going to encourage people at this point in time. I mean, the fact that we're virtual, we can still go to an exhibit hall. We don't necessarily have the opening session, you know, the wine and cheese, but maybe you can pour your own little glass or cut a few little pieces for your own. But while you're in there, there's a lot of virtual rooms you can go into. The exhibitors are ready to display their wares. You just have some great technology that's being shown. You can win prizes. You can play the Woundopoly, and there's the passport to the various prizes contests. There's just many ways, and it's really good to be able to help support the people who are sponsoring our symposia and to keep it going, because particularly during this tough time, and I just know that I had a good time when I did go in and look at the exhibits virtually, and I really am looking forward. I really hope we're live come this spring in the Dallas area. So everybody, thank you for attending our rapid fire poster session for our fall SAWC 2020 virtual. Look forward to seeing you in springtime. Thanks.